Hello. In this video, we will talk about intubation, what that would look like for a patient, why we intubate, and some items we will need for our physician or our anesthesiologist or those who appropriately trained will intubate the patients. Nurses generally are not trained to intubate patients unless there are some special circumstances, and that would simply be all according to hospital policy and their role. But as a general rule, we do not normally do any type of intubation for our patients. Let's get started. So, obviously, you will need an ET tube or endotracheal tube. This, our physician or whoever is going to intubate the patient will tell you approximate size that they would need. An adult male may be different than adult female depending on the size of the patient. Of course, we will use pediatric, that will be a lot smaller if we had a pediatric patient. For the purpose of this video, I will show you a pediatric patient's ET tube or endotracheal tube, but I will focus on an adult ET tube, and I will find a larger one just so that you can see what it is that I'm doing. So, reasons why we might want to intubate someone or create an artificial airway. That's what we mean when we say intubate. We have had respiratory failure. We feel like our patient is headed toward respiratory failure, or we have some other reason to intubate the patient because they can no longer protect their airway. Whether that's a patient that's seizing, it could be a patient that has various conditions like a stroke where the brain no longer controls the breathing. All of these things can be used, and obviously a cardiopulmonary arrest or respiratory arrest would negate us having to do, or I should say, should be a real cause for us to start intubating on a patient. Now, let's figure out what things we would need if we were going to insert an artificial airway, or at least prepare the items for the physician or anesthesiologist or nurse practitioner, whoever is going to intubate the patient. All right, this is an ET tube that's an adult, and I said I will talk to you about a very large one just so that you can kind of see where we're going. Now, this would be probably for a larger patient, preferably we hope that's a male. This is our normal ET tube right here. It has a cuff on the end and has a pilot balloon so that we can know how inflated our cuff or balloon is on our ET tube. This is a solid or guide wire that we would use. We would place it inside of the tube, but we would never want it to come out of the end because it could cause damage to the patient's trachea or windpipe as we know it. So that's our adult. I will show you a pediatric with also that has a guide wire, and if you notice that our pediatric does not have a cuff. So this one's a little bit tinier for one of our children or child. On the side of your ET tube or endotracheal tube, there's a size for this tube. And so this is also a guide wire that we would place in for easy intubation so that we can have some type of support for our tube. So also on your package, you will find the size. The size of this one is a 2.5. The size of this one, obviously, I would say, venture to say, is an 8. Okay, so an 8 or a 9. But this is an 8, so it's kind of big. All right, I'm going to let those stay here. All right, now, other things that you would need outside of your ET tube, I would go ahead. Respiratory is also a great resource. If they are available, they will normally come and help you with the intubation of the patient. You need an ambu bag. And this ambu bag, for it in the beginning, will have your face mask on it. So it'll actually go over the patient's face, nose, and mouth with the point, the tip up, okay? And then once you get your patient intubated, you will remove this face plate, and you will only use this tip right here. So I'll start off with this because I want to tell you why you need an ambu bag prior to intubation. All right. So we'll have that. This is our tubing or oxygen reservoir bag here, and you would attach this to the walls for oxygen. You also want to go ahead and set up suction if you have it. You definitely need suction if you're going to do an intubation for a patient. Now, things have gotten really advanced now. We at one point in time would grab blades or laryngoscopes as they call them. Okay, this is a Miller. And then this one is a mat. It's curved. And your physicians would, kind of choose what would be their preference. So when you flip it, the light should come on. You always want the light to come on because this will allow you to be able to see the vocal cords as they're getting ready to pass the tube into the trachea. So both the lights you want to open up and figure out if your light actually works. So both of these lights actually work. So again, the Miller is here or a mat. Physicians will choose which they would like to have. The thing that we're using now in modern medicine is something called a glidoscope. And that is a scope or a video machine that will allow us to review or view the vocal cords on a screen. So they have now what we call glidoscope. But if your hospital does not have a glidoscope, we go back to the old laryngoscopes, which is a Miller and a mat, okay? Little bit of tube lubrication. Your syringe, because on your syringe, and again, I'm going to focus on the adult, and we have our little balloon here. You will have to attach your syringe so that you can inflate once you have it in place, once everything is in place. And then your end-tidal CO2, you'll have one of these to attach to determine if we have it in our patient's esophagus or stomach, or do we actually have it in the trachea and to inflate the lungs. So we would want one of these. We would always want to make sure we had our patient on a monitor, that we're monitoring them at all times. We can also monitor their CO2 levels on our monitor, but at this point, rapid sequence intubation, we would want to get some type of paralytic agent medication. We want to paralyze our patient. We would also want some type of sedative, to make sure that our patient is sedated and paralyzed. We never want to sedate someone and not paralyze them. One, muscles and things are still moving if we're not paralyzed. Two, if we sedate them and we're working with them, then they can kind of know if they're not all the way, if it's not an arrest, like a cardiopulmonary arrest. All right, so we have everything that we need at the bedside. We're ready. Physician comes in. Your patient is going to be in what we call the sniffing position, meaning that we lift their chin up and the nose up into the air, what we call sniffing, so that we can easily see the vocal cords. Everything that you have set and laid out is ready to go. Your patient has an IV access, and the doctors has now went ahead and provided this patient with a sedative and a neuromuscular blocking agency or some type of paralytic agents. We would hyperoxygenate your patient. That's why I wanted this to stay on. So in the beginning, before you intubate, you would give your patient oxygen if you could. So someone's constantly bagging your patient to give them oxygen, and we can do what we call hyperoxygenate them. Then we will go ahead and the physician or anesthesiologist or whoever performing the intubation would at that time go ahead and do the intubation. So these are all the things that you would need set up. Now, once we get the patient intubated, everything's well, we can now take our little face mask off and we can insert our, because our guide wires has been removed, we can now attach our ambu bag to the top of our ET tube, and at this point in time, we can bag until we attach our patient to a mechanical ventilator, and at that point, we want to, before we ever put them on the mechanical ventilator, to determine if our tube is actually in the correct place. So how do we do that? We take our stethoscope, we listen to the lungs to make sure air is going in on both sides. We watch to see if our chest is going to rise and fall on both sides. We also do a chest x-ray, and on this little tubing down the middle of it, and I don't know if you can see it if I bring it closer to you, there's a little line that's right here that shows up in x-ray. It's a little opaque line that kind of glows when the patient has his chest x-ray. So you want a chest x-ray, you want to listen, You want to look, you want to see that both chests is rising and falling on both sides. Now, this little CO2 detector, you don't have them on one on the, you don't have them attached to it. You would attach it to this and then attach this to your tubing. And then once you, and this is how it goes, just like this. So you've got your CO2 detector attached to your ambu bag. And so once I breathe in for my patient, I give them air. Air is going to naturally exhale. So the patient will exhale. Once I inflate the lung will deflate naturally. And so what you're looking for is that this little thing here turns gold. Gold is that's carbon dioxide. If we start to see other colors like the blue, the purple, then we may be in the patient's abdomen and to the stomach. Now, if your patient has chest rise and fall only on one side, that means that we may have taken the tube into one lung and not the both. So we always want to have both sides of the chest rising and falling. We want to look at our chest x-ray to see the position of it. Then we attach our patients to the ventilator. We secure our tube so that it does not gets pulled out, and then we do our charting. We chart the size tube that we had, how they tolerated it, and did you auscultate your patient's lungs? Where is it secured? Is it secured at the lip? Because there are numbers on your ET tube. There are numbers that go down the side of that, and so you want to know what number is actually at the teeth or the lip in the charting. Okay? Thank you so much. I hope you enjoyed this video. If it brought you some joy or if you learned something, go ahead and hit the like button, subscribe to my channel, and you'll know when more videos are coming out. Until then, learning is always fun and we are always learning.